The International Association of Oral and Maxillofacial Surgeons welcomes you to the third day of the 2022 IOMS ALICIBU NextGen Online Conference. We would like to thank our Emerald level sponsor, KLS Martin, for supporting this conference. Please note, today's session is being recorded and all participants will be muted during this program. Personal audio or video recording of this program is prohibited. If at any time you experience technical issues, please utilize the chat feature within Zoom to contact staff directly. Today's session will be moderated by Drs. G.E. Gali and Edwin Ramirez. There will be a question and answer session once all presentations are complete. When submitting your question, please include both your name and country. This conference also includes simultaneous interpretation from English to Spanish. If you would like to utilize simultaneous interpretation, select Interpretation in the Zoom menu below and select the language channel. The 2022 Abstract Gallery is now online at ioms.org. Please note that recordings and certificates of this conference will be available at a later date, and registrants will be notified by email. It is now my honor to turn the event over to moderator, Dr. G.E. Gali.
Good evening, good morning, depending on where you're from. My name is Gali, and I'm the chair of the Education Committee for the International Association. I'm very proud to be co-moderating this session with Professor Dr. Edwin Ramirez from El Salvador. Thank you very much, Edwin, for joining us and co-moderating this session. Tonight, we have 6 wonderful speakers from all over the world, and they all have expertise in various aspects of orthognathic surgery. The title for today's speech or today's presentation, today's conference, is Evolving Protocols and Practice in Orthognathic Surgery. This is part of a 5-day program, which includes live presentations, as Xander just mentioned, along with question and answer opportunities. Each session includes more senior surgeons, as well as the next generation, or the so-called next-gen surgeons. So we're very, very happy and very proud to have everyone here tonight. I know that there's quite a few people and quite a few registrants that are coming on. So welcome to everyone from around the world. I want to point out that this Zoom call is being simultaneously translated into Spanish for our colleagues that are primarily speaking Spanish. Please note the question and answer box at the bottom of the Zoom. That question and answer box will be utilized to submit questions to the speakers. At the end of the presentation, we will then, at the end of the last presentation, we will then allow the questions to be answered. I will be fielding the questions. So when you submit a question, please include your name and which country you're coming from. Without further ado, I would like Professor Ramirez to go ahead and introduce our first speaker.
Thank you, Dr. Gali. Good evening, everyone. Welcome to this scientific event. It's an honor for me to introduce you to Dr. Mai Yu Yang from Hong Kong with his presentation on prevention and management of common complications, sagittal split ramus osteotomy. Please pay attention to him, Doctor. We are here.
Thank you. Thanks for the very kind introduction. Very nice to meet you all. I'm Mike Leung from Hong Kong. Can't speak Spanish. Hola. Thanks for the invitation from IOMS, and it's always my honor and as well as my passion, especially to lecture to the Next Gen conferences. So the topic today I'm presenting is the prevention and management of common complications of surgical split ramus osteotomy. So, as we all know that surgical split ramus osteotomy is the most used orthognathic procedure for the mandible. I would say probably 99% of the mandibular ramus procedure in the world are performed by BSSO or SSRO. So this is a very common and very useful workhorse because it can set back the mandible, it can advance the mandible, correct its symmetries, in any kinds of deformities. It is has some use. So this lecture on the common complications of BSSO. And I hope you will all can understand the etiologies of these common complications. Hopefully we'll give you some tips on the prevention as well as on the management. So what are the common complications of the sagittal split ramus osteotomies? Well, definitely first comes to mind will be bad split, because that's kind of a nightmare even for senior surgeons. Bleeding. There are problems in the segment positioning, as well as the most famous nerve injury. So let's first look at the split. It is about the sagittal split. So most important part of the procedure is splitting the mandible, and the split is the most challenging. How can we make a good split consistently, like a master? So I come from the east side of the globe, depends how you see the map. So this is a taekwondo master that in Korea, they can easily break, split anything. But the first legend that developed this, of course, is we all know is the late Professor Hugo Orbigisa, who developed this technique after looking at the mandible for some time and starting his first try in real patient. And it was a ramus that unexpectedly shattered, that he did not do very well. He was kind of unsuccessful. He didn't give up. He gave it again a try and was quite successful in the second try. However, in the third try, it was unfavorable fracture again. And the worst is it was on a private patient of his boss. So he said he went to a monastery church and prayed and promising God that he will never do it again if this girl got away without any complications. Luckily, he didn't really fulfill too much of this, and he goes on and keep doing it, and then that becomes the most useful orthognathic procedure in the world. And afterwards, we have a lot of modifications, and we will hear later today also a low-level cut of the medial cut. There's also one of the modifications that is useful. So we have to understand that what are the risk factors. For example, like Professor Orbigisa, when he first tried, he is definitely an inexperienced operator, and 2 out of his 3 first tries that he has a bad split. So we have to understand that inexperienced operator is risk factor of bad split, and we all have been or are a inexperienced operator, because depending on what process are you in your stage of career, that we are all learning orthognathic surgery. But please note that it is a learning curve, and we have to understand that this learning curve happens to anyone, and we are no genius, and we all have to understand some people may learn faster, some people may take a longer time to learn. Also depends on who are the teachers and who are your trainers. And as trainers like myself, we should always allow our trainees to learn through failures, and we have to understand that this happens, and even in the most experienced hands, sometimes it happens. Age is a factor. There's a published meta-analysis showing that the increased age over 30 years old has a higher chance of bad split. Is presence of third molar a risk factor? Well, there are people saying yes, there are people saying no. So Professor Becking, who is one of my most respected orthognathic surgeon in this world, and also my very good friend, has published a meta-analysis, and in fact, the evidence says no. So believe it or not, you may have different, of course, there are different impaction of a third molar. If it's very low down to a low border, maybe the risk may be higher, or it obviously weakening the third molar, or with any like cystic change or pathologies, that may be having a higher risk compared to a normal impacted third molar. But in general, from the evidence, we can say it is not really a risk factor if it's done properly. So we have to understand the anatomy of the mandible, and I think personally, my personal opinion is that thickness or maybe the length is a risk factor of the mandible, of a bad split. Just taking one example, this is a asymmetry case, a patient with facial asymmetry, which is very common in Hong Kong. Is the lower jaw shifted to left side because the right side is longer. So when we look at the CT scan, the rendered CT scan and the cross section, we can see that the longest side, which is the right side, is much thinner at the ramus area compared to the left side. You can see there's still cancellous bone, there are two cortexes on the left side, while on the right side the cortexes seems to fuse with each other. So surgical split, you have to understand we are splitting between the two cortices and in the cancellous bone. If there's no cancellous bone, if there's a monocortex, then it's really by chance that it may go either way. So a bad split is highly likely if it is monocortical. So I'll take this example as a dough. When you make bread, or when you pull it, it will be thin. So our mandible is the same. We have a certain amount of bone. When we grow, it may become thinner and thinner, and when it's become very long, it will be more thin. So if you go to China or go to Japan, we make noodles by keep pulling it, and then the more times you pull this dough, thinner the noodle will be. We must also realize that some risk factors are unavoidable. Okay, so it's not the surgeon's problem, it is the anatomy. And extra care and preventive measures are needed in these cases. We have to understand that surgical split ramus ostomy is a standardized procedure. It is standard no matter how it is. Most of the time we do in one standard way or with some modification. But after all, this is a standard procedure. However, each mandible has a different anatomy. And specific cuts are important to reduce the risk of bad split for this standardized procedure. So to me, that's how I always tell my trainees, the most crucial cut is the lower border. Okay, so if you go through the lower border sufficiently, then the chance of bad split is much reduced. So you have to make sure that the burr goes through the lingual cortex. How can we achieve that? Make sure the patient closes his mouth when you're doing the lower cuts. Because when the patient opens the mouth, the soft tissue and the muscles will be in tension, and then it's hard for you to access as perpendicular as possible. We are doing an intraoral approach, we are never approaching it perpendicularly. But the more you go perpendicularly, or as much as you can, the more likely you can engage onto the lingual cortex that will avoid a bad split at the buccal bone. So afterwards, we'll go up and you'll go back. You can use a saw, you can use a burr, it's really no difference. Okay. Personally, I don't go too far up to the teeth because if the further you go up, the more medial you will be. So there's higher chance of exposing the nerve. We go up with a ramus retractor, and usually I don't expose the lateral side because it's not necessary, and I try to keep as much blood supply to the proximal segment as possible. And remember, we always put a mouth prop when we are going up to the medial side. Exposing the medial ramus, putting a retractor at the medial ramus to protect any soft tissue, any blood vessels and nerves there. If you can't really see where you're putting, you may use a acrylic burr to open up a bit so that the visibility and access will be better. And then, of course, we know that we do a medial cut, again, either by a saw or a burr, above the lingula. So the classic teaching is that we bisect to two mandibular and maxillary occlusal plane with this angle, and going below 5 millimeter below the sigmoid notch, which is definitely above the lingula. This is the classic teaching. And it should be, and this parallel to the bisection of the two occlusal planes. So after the cuts, we join it. That is standard. I don't have to teach you all this. This we all know. That you can join again with a burr or with a saw. However, if you are having a elongated or a mandible, for example, like a symmetry that the thinner side, or is a very long class 3 mandible, or in an older patient, what I would recommend a slight modification is that, first of all, you go find a lingula. Not everyone will go to find a lingula. I know many surgeons just go in, cut, and split the mandible. They don't find a lingula. However, if you have a very thin mandible that you expect a higher chance of bad split, go to find the lingula first. And do a medial cut immediately above the lingula. Remember, if we go down, the lower we go, the more thick it will be. So more likely you can capture more cancellous bone. And instead of bisecting the two occlusal plane, what I normally do is I will follow the upper occlusal plane. So the back part of this cut will be tilting down rather than tilting up. Otherwise, if you tilt up, the cuts will be higher and a higher chance of a monocortex the higher it is because of the very thin mandible or older patients. So try to go parallel to the upper occlusal plane and tilt down as much as you can and immediately above the lingula. Of course, then we go with some chiseling. You can just be careful doing different levels of chiseling. Use an APCA and then a 8mm osteotome, and then you may use a splitter. When we split it, you can be extremely fast, but that is more dangerous, either to the bed split or to the nerve. So when we split it, you may, if you have this is, I think it's very useful. It is a splitter of the BSSO, and we can gradually open it. If you see anything wrong, for example, if the top part is still connected, you may go in and do a bit more osteotomy to make sure that the proximal segment carries the condyle. And when we do the split, try to stay slow and be careful. So just some practical tips. Lower border and medial cuts. And double check these two cuts before splitting. Okay, just something, if you don't remember the whole thing, just remember these two. So the problem is, if it's really having a bad split, what should we do? Well, I'll put it in a sequence. I think this is important that we have step-by-step management of a bad split because it happens to anyone. First of all, I think it's important to identify and visualize the situation because this bad split can be anything. It can be anywhere. And you have to understand there are two problems in the bad split. First of all, you can't set back the mandible. And the condyle is still connected to the main body. So you cannot perform your orthognathic movement, either setback or advancement. Again, there will be difficulty in fixation because of the bad split, because you have a loss of the buccal plate. So for example, if you bad split like this, so this comes out as one, and this stays the same. So the condyle is still connected to the main body with the coronoid. So you have to understand, first of all, you need to separate the condyle from the main body. Otherwise, you cannot achieve your movement and your whole procedure will not be proceeding. You have to separate it, 1, 2, and 3. And the next step, if possible, try to fix the condyle segment with the bad split. So this is what I have done in this particular case. So I'll fix 1 to 3 by some leg screw, by a transbuccal choker and a leg screw, and this patient have a good outcome and a good occlusion. So back to the gentleman that we have a asymmetry. That was also a bad split, and what we did was in the last contingency plan, you have always something in pocket. You can do intermaxillary fixation and remember to fix the buccal plate. Don't take it out, don't throw it away, don't just randomly fix it. We still have to fix it in a proper manner. So what we normally do is IMF for 6 weeks. At least it is allowed in Hong Kong. So we make sure that the bone heals, and with bone contact, it should be fine. And you can see that the condyle separated. So in this case, that we didn't manage to fix the bad split to the rest of the mandible. So what is important here is that you have to see, I've still put a sagittal split plate on, like this. That is a standard. And I also put a leg screw to compress the bad split segment back to the original position. Because if you just put a plate on, it may flare out at the back. So the compression will allow that the mandible's shape is still controlled. Otherwise, you may end up with a wider face. So before and after, there's no problem. Of course, he suffered 6 weeks of intermaxillary fixation, but at least the outcome is good. So bleeding, the next complication that we may encounter. This is something we all see, but big bleeding is rare in BSSO. The usual size is usually at the inferior alveolar vasculature together with the ID nerve, or it's a branch of the external carotid artery, especially the facial artery that comes where you do the lower border cut. So be very careful. I think that is totally preventable for cutting the facial artery. However, for the inferior alveolar artery, you have to understand that it's usually above the inferior alveolar nerve by anatomy. Most of the time it is above it, so if you cut too close to it or when you split it, you have to bust only the top part of the vasculature instead of the whole nerve. Otherwise you end up with a nerve injury for sure. Segment positioning. Well, from learning from Isaac Newton that there's an action and reaction to our movements. When we do a big advancement or big setback, sometimes the condyle, the proximal segment may be deviated and it may be spread out and the patient will end up become a hamster. That is something aesthetically not favorable. So if you're doing a big advancement with a very wide mandible, if you compress it to adapt, you will have a reaction force laterally out, and that will cause pain at the condyle. A lot of temporomandibular joint disorder after sagittal split radius osteotomy is a reason for that. So what can we do? The easy thing is infracturing the lingual plates to allow a better adaptation. There is some flexibility of the joints, but you don't want to stress it too much, otherwise you have temporomandibular disorder. So this is one case to demonstrate. We have now all used virtual planning, and that's a very useful tool, and we can predict where are the bony interferences. As you can see that the right side, there is a lingual plate problem. So if you want to press to have a good adaptation on the right side, the red portion, onto the yellow portion of the mandible, you will end up with a force of the condyle area out of the fossa that may cause pain. So what I would suggest, if you want this for a better adaptation, if you press onto here, then you have a condyle problem. So what I would suggest is that you first of all have to find a nerve, the nerve that goes, the inferior alveolar nerve, you have to dissect it away. If you want to do a lingual split at the area, protect the nerve and try to reflect it and protect it. You can cut above and below and try to join a crack, and then you will be fine. And then you can do a safe lingual split there. So last, I want to share that lingual nerve injury, the nerve injury in orthognathic surgery. Sometimes it's unavoidable because a lot of tractions we split will expose the nerve in the mandible. But nerve manipulation are unavoidable in many cases. And I've published with my trainee, who is now the head of department in Saudi Arabia, in a cross-sectional study with 476 slides of orthognathic surgery, approximately 10% have a permanent nerve deficit. But however, there's zero no suitcase, none of them are suing us. So in this, I want to keep your focus to the overall percentage. It's approximately 13% for any mandibular procedures having a inferior alveolar nerve deficit in 2 years in long term. However, for those who have a nerve deficit, all of them stays very, very mild. So from 10 to 0 is approximately 1 to 2. So if you encounter a nerve injury or even a nerve tear like this one, when you open it, you see that the nerves are separated, maybe during the split or maybe you cut too low. You can repair it, hopefully a tensionless repair. I'm not going into deep details of the technical parts, but this one shows if you want to mobilize the nerve, you sometimes have to mobilize it from the mantle foramen. You have to lateralize the whole nerve so that it will be a tensionless pair, especially if there is a rotary instrument injury, you will have some tissue loss and you have to remove a portion of the damaged nerve in order to have a good repair, like this. So like this case, approximately you gain up to 80% of the normal sensation in 1 year. So for this lecture, my sharing is that sometimes bad split, nerve injury, and some other complications are unavoidable. Even in the most experienced hand, these are unavoidable. We are all learning, even in senior people, we are all learning every day, and we hope to avoid the avoidables. And if it happens, manage according to the principles and don't panic. And patients should be well informed of this possible risk. And if they are expected to something may happen, they will be easier for them to handle. So once again, thanks very much, and it's my honor to present in this conference. Thank you.
Thank you very much, Mike. Wonderful job. I will again remind everyone, thank you for staying on time as well, Mike. I want to remind everyone, all of the participants, we have nearly 200 on live right now, to submit any questions that they may have in the question and answer box, and we will do our best to answer those live at the end after the last presentation. Our next speaker, Jonathan Klaus, Dr. Klaus from Brazil, will be speaking on minimally invasive orthognathic surgery. Dr. Klaus.
So thank you very much for the invitation and for the introduction. I think I still belong to the next generation. I prefer that than to be called as a professor. So my name is Jonathan Klaus. I'm from Brazil. And to start this presentation, I would like to ask this question. Why should we consider a minimally invasive orthognathic surgery? This study evaluated the patient's perception in the short term, 4 to 6 weeks post-operative. And what they found was moderate to severe dissatisfaction in almost half of the patients related to numbness and swelling. This other research revealed the patient's experience regarding pain was 47% worse than expected. And in relation to edema and paresthesia, this index was also very high. And it was very curious. This other article was after what patients post in internet forums about orthognathic surgery. And in the third position are patients reporting complications and problems with the result. Among them are when they feel unrecognizable, with a locked smile, the nose widening, the late swelling, bone defects, and also asymmetries. Anyone knows what I'm talking about. This video went viral, showing a complex recovery that generally scares lay people and especially family members. But we don't even need to go to the internet. I can share this result with you from a patient I operated 10 years ago. This is how she looked like 3 days after surgery. A lot of swelling, ecchymosis, and here she is now at 3 weeks. Still having trouble recognizing herself, regretting having the surgery. And even though the final result after 2 years was pretty good, pretty reasonable, the truth is that this surgery scared her and many people around her. This reality is what made us go after changing the type of surgery and today we have this concept of minimally invasive orthognathic surgery. In the next few minutes, we will show part of our work. This is one example, a patient 12 hours after surgery. And this is how she looks, unfortunately, is in Portuguese, 6 days after surgery, returning completely to her social and work activities. Regarding the modifications of the surgical technique, we will highlight these 7 main points. The first step is the incision. with a maximum extension of 2 centimeters without using an electric scalpel. And when we look at the appearance of this type of incisions after 3 months, we can see that the area of fibrosis is much smaller, and this is very important, especially in the maxilla and in the genioplasty, to avoid jeopardize the movement of the lips. The second difference is on the soft tissue dissection. On the right, we have the image of dissection and fixation in a conventional surgery. In the image on the left, we have the scenario of a minimally invasive surgery. The more tissue inserted, the greater is the blood supply. That's when the question arises, where bone healing is faster? I don't have proofs, but I can guarantee you that on the left is faster. The third difference involves the muscles of facial expressions, which we can divide into 2 main groups according to the depth, the superficial and deep layers. And this article is fundamental for understanding this, where the authors analyzed in cadavers the impact of extensive dissection of the muscles of facial expressions. And both groups, the superficial and deep layers, are directly or indirectly affected, which may impair the facial expression movements. That's why the title of the article contains Unrevealing the Mystery of the Level 1 Lip. And I have another example from my own clinic. This patient received a conventional maxillary surgery. Initially, she had an excellent post-operative that even encouraged me to take pictures at 24 hours and then at 1 month. But when we compare preoperative smile with the result after 4 months, we notice a difference in the movement of facial expressions. This same idea applies to the genioplasty, where the dissection tunnel retains as much tissue as possible. The fourth differential is in osteotomies. One of the major concerns with maxillary surgery is the nose widening. Again, these are also examples of patients of my clinic from the past. The same problem, nose widening. The modification of the subspinal osteotomy allows for the maintenance of the entire soft tissue sphincter. This soft tissue sphincter acts as a scaffold to prevent widening. Since that, the problem stops happening with all of our patients. Still in the maxilla, the design of the level 1 osteotomy is basically the same. The difference is in the separation of the pterygoid plate, which is performed with the twist technique described by the group from Barcelona, which avoids the trauma in this area and a lot of complications. This is a transoperative example of how this is done with a sequence of instruments that we adapted for this technique. The first chisel in, and then we promote the twist movement to move the maxilla downwards. Talking about osteotomies, although this article does not mention any word related to minimally invasive technique, here's the best way to summarize our preferred technique for mandibular osteotomies. The title, Finding Balance Between Classical and Short Techniques. On the left, we have the representation of what could be a conventional technique or Bosnick short split or Wolford step. They all end in approximately the same position in the middle of the mandibular body. In the technique that we call anterior oblique, the end of the osteotomy is moved posteriorly in the angle or sometimes in the ramus. This has several advantages, especially the preservation of the jaw contour, avoiding the risk of notching, which is a palpable or visible bone defect in cases of large advancements. This is the aspect in the immediate post-operative CT, and this is the effect obtained in the patient with the gain in the vertical projection of the angle and also the linear and natural contour of the mandible. The fifth point is the fixation. In the mandible, our preference technique is for the hybrid technique, which is already well known in conventional surgeries. The big change is in the maxilla, the fixation with only 2 mini plates, and also the fixation of the chin with only 2 bicortical screws. All these options are supported in the literature. Regarding bone grafts, we basically follow what was described in this systematic review, highlighting the need to fill gaps, sometimes to accelerate bone repair and sometimes to avoid bone defects. And finally, in the sutures, the main objective is to avoid the formation of large fibrosis. So the short-term benefits of a less invasive surgery are already known. Less swelling, less pain, less numbness, shorter hospitalization, shorter return for social and work activities. The final result is less morbidity and a faster recovery. But what our group has been seeking to understand are the mid and the long-term effects. We have no doubts that the bone repair is accelerated in this type of surgery. And with that, in the midterm, we have a surgery with less complications that can also allow shorter treatments. This is an example of a larger maxillary advancement with inferior repositioning. This is a transoperative placement of bone grafts, also with the post-operative CT. So we are seeing small incision with a lot of soft tissue inserted, only 2 mini plates and bone grafting. With 3 months, we note the stability of the maxilla and the occlusion. So this is a video checking the stability of the maxilla. The same in the follow-up with more than 1 year after surgery. The vertical stability of the maxilla, horizontal projection, and also the occlusion. But what are the potential benefits in the long term? Well, the first point is the formation of less fibrosis. Once again, I understand the importance of this for the maxilla and the chin due to the movements of the lips. Maybe in the mandible, this is not so important, but for the maxilla and the genioplasty, this is so important. So this is a video 10 days after surgery, and this is how the incision at the chin looks like. 10 days after surgery, removing the sutures. And now is the patient 30 days after surgery. The second point is the lymphatic irritation. This is another example.
Oi, meu nome é Isabela.
Once again,
sou
Portuguese
paciente
in
do Dr.
Portuguese.
Jonatas. Estou com 24 horas de cirurgia.
Oi, bom
One
dia.
video with 24 hours and the second one with 48 hours. The less the invasion, the less the permanent damage to the lymphatic drainage, which means the less the late swelling. The third point is breathing, because the larger is the transport segment in the mandible, the greater is the tension in the soft tissues, bringing a higher impact on the airways. The fourth point is to avoid the formation of bone defects. Again, this patient was operated by myself. This kind of defect happens a lot. But when we dislocate the end of the osteotomy, we avoid the risk of notching, at least visible. The fifth point is related to nose aesthetic. This subspinal change osteotomy, this change at the subspinal osteotomy, and the minimal dissection of the soft tissue allow a better aesthetic result in the nose. This is one example with a larger maxillary advancement. And finally is the aesthetic of the smile, our biggest goal. As we've discussed, the greater the preservation of the soft tissues and muscles, the lower is the negative impact on facial movements. So, answering our initial questions, I believe that we have many reasons to think about a minimally invasive orthognathic surgery. Here are just a few. We still need to assess the mid and the long-term effects. There is no question that there is a clear benefit in the short term. We can significantly reduce costs, material, hospitalization. And also there is the commercial effect. Nowadays, there is a natural search for minimally invasive procedures. Finally, in June of this year, we will be having the Brazilian Congress of Oral and Maxillofacial Surgery, the biggest event in America Latina. I would like to invite everyone to know my city, Florianópolis. This is the place. As well as this school, that is our logo. Our city is safe, is friendly, is a modern city, and just like our Congress, we are gonna have a lot of fun. So thank you so much again for all the commission. I will be available at the end for the questions. And once again, thank you, everyone.
Thank you. Thank you very much, Dr. Klaus. Our next speaker will be introduced by Dr. Ramirez.
Okay, thank you very much. It's time to listen to Dr. Mohamed Gamed from Egypt, presenting short low sagittal ramus osteotomy, versatility of application. Welcome, doctor.
Welcome everyone. If you can just give me 1 minute to set up my my Zoom meeting from my laptop. So
while we're waiting, I just want to remind all of the participants to submit their questions. Please include the country that you're submitting the question from, if you don't mind. And I'll do my best to get all of the speakers to answer the appropriate questions. How are you doing, Mohammed?
I'm doing fine. Just joining in 1 minute.
Recording in progress.
Okay, so I have joined from my laptop.
Do you need more time, Mohammed, or do you want, we can go on to the next speaker till you can work on it? I think you're muted, Mo.
Yeah, I just need 1 minute if that's fine. Is next speaker ready? If you can start.
Well, shall we go on with the next speaker, Mohammed, while you're working on it? Why don't we go on to the next speaker, and then we'll come back to you, Mohammed. Our next speaker.
Yes, please do that. Sorry.
Okay, thank you. Our next speaker, Dr. Caitlin McGraw from the United States. Her presentation will be Beyond the Traditional Paradigm, Personalized Orthognathic Surgery. Dr. McGraw, welcome.
Perfect. Thank you for the introduction and the opportunity to speak today. So I have no disclosures, and we're hearing a lot about how orthognathic surgery has changed today. I'm really excited for the future, and I want to talk a little bit about that. And when we look with where we started, right, talking about Hubert Obergazer and his early surgeries, and then how antibiotics change medicine and what we can do, general anesthesia, how it's evolved and allowed us to treat more complex cases more predictably. And of course, the introduction of rigid internal fixation and how that has completely changed our ability to get predictable, stable results. And of course, within the last 2 decades, the introduction of virtual surgical planning, which has really taken over and given us a lot of opportunity to customize surgical procedures. And so I think the arena we're entering now is really looking at personalizing orthognathic surgery and really more patient-centered care. And that's what I want to talk about today. And so what is patient-centered care? Well, problem-centered care defines a patient by a problem or disease, and it really is more a rigid treatment pathway and a one-size-fits-all approach. Whereas patient-centered care treats patients as individuals, and it relies on a strong doctor-patient relationship built on trust and shared decision-making, and it gives patients a voice in their treatment. And when we think about orthognathic surgery, this is the approach we usually use, most people use, right? This is the conventional approach as it's described. So it involves 3 phases of treatment: pre-surgical orthodontic treatment, surgery itself, followed by post-surgical orthodontic treatment. And so the question I pose to the group is this really a patient-centered model of care? And is there room for improvement in this model as we move forward? And this is a model that's tried and true, right? So this is a patient treated with a conventional approach, mid-face hypoplastic hypoplasia, mandibular asymmetry, undergoes orthodontic preparation, has surgery, postoperative orthodontic treatment, and has a very good outcome that's quite predictable. But the question is, how can we do better, and how can we get these results in maybe a different avenue that's a little bit more patient-centric? And so how do we do that? Well, when we think about orthodontic surgery, we can personalize the orthodontic treatment process itself. So what type of aligners we're using, right? Are they fixed? Are they clear aligners? We can look at surgery itself. We can use custom splints now, cutting guides, individually created hardware for different types of defects and problem solving. We can modify the osteotomies. And the really nice thing, of course, with virtual surgical planning is you can plan those different osteotomies and see what works best for you. And then, of course, this is becoming increasingly more important, that we need to really figure out, how does the surgical procedure that we're doing to this patient help them as an individual, right? So we can really try to do identity affirming operations. And in Portland, Oregon, gender is a big part of patient's identity and what I treat. So for example, yesterday I treated a pre-op patient who is a female and identifies as a male. And we had a long conversation about the changes in the chin segment position and how that would play a role in their gender identity. And so that becomes a really important part of this. And then, of course, the timing of the operation. So whether we're using the conventional model where we're doing surgery first or even early surgery. So let's look at some of these things. So first, I wanted to start with just clear aligners and kind of my method for treating patients who opt to move forward with clear aligner treatment. So this is a 39-year-old male, comes to the office for orthodontic surgery consult. We talk about the conventional model and what to expect. And he says, look, I'm up for surgery, but absolutely no way am I going to have fixed aligners. He's not interested in that, right? He doesn't want any appliances on his teeth. He's a professional and just really can't move forward with that option. And so he elects to move forward with clear aligner treatment or Invisalign treatment. And here you can see his preoperative photos, mid-face hypoplasia, mandibular asymmetry. You can see a significant incisal wear secondary to that malocclusion, which he's had for so long. And now he has his orthodontic buttons in place, moving forward again with the plan for clear aligner treatment. And here's his preoperative imaging. He undergoes orthodontic decompensation and his treatment plan for Lafort 1 for maxillary advancement and BSSO for asymmetry correction. And you can see with my clear aligner cases, what I usually have the orthodontist do is bond these little buttons along the cervical margin of the teeth. And I can use these buttons intraoperatively for intermaxillary fixation. So I don't have to place IMF screws. It makes it much quicker in terms of, moving forward with skeletal fixation placement and not having to place anything else. And of course, IMF screws are generally not well tolerated by patients. They really don't like them. So if I can get the orthodontist to bond these little buttons on, I include that in my preoperative VSP plan so they're scanned in. I can create occlusal splints that avoid these buttons, and then they can be used for postoperative elastic traction in the postoperative phase, which is really helpful. And here you can see this patient's postoperative imaging and a really nice occlusal result for him. Obviously still undergoing a little bit of orthodontic detailing, but overall a really nice change and never had to have any fixed appliances placed, which was really important for him as a professional. And so looking more at surgical procedures and what we can do, well, as I alluded to, custom splints, cutting guides, and hardware are really critical tools we have in our toolbox to treating some of these more complex cases now. So this is a 14-year-old boy, has a very rare potassium channel deletion. There's only about 10 reported cases in the world, one of which was his sister. And you can appreciate from these photos, he's wheelchair bound. He has maxillomandibular deficiency. He has a history of seizures and has been on anti-epileptic medications for many years and has significant gingival hyperplasia secondary to those medications, which makes it a little more difficult when you're talking about occlusal splints and planning surgical movements. And what you can see here is this is his breathing at baseline. And so what actually had happened, and you can hear him obstruct here, is that he underwent a cervical fusion about a year prior to me meeting him. And while before, when he would obstruct, he was able to turn his head and he would be able to alleviate that obstruction. After his cervical fusion, he was unable to do so. And so he would have to have a caregiver that actually followed him around and would give him jaw thrusts to alleviate that obstruction. And in fact, his sister, who also had the same potassium channel deletion, actually passed away at age 15, secondary to an obstructive episode. And so you can imagine the family was very motivated to move forward with treatment. And of course, my initial reaction was to move forward with a tracheostomy, but given his love of swimming, the family really wanted to talk about other options. And so ultimately we decided to move forward maxillomandibular advancement without undergoing orthodontic decompensation, given the urgency of the issue here. And so you can see that this is his surgical plan. I did inverted L osteotomies. Pagonion came forward 30 millimeters here, segmental Lefort 1 for advancement and transverse expansion as well. And because, again, his teeth, the majority of them were kind of embedded in this gingival hyperplastic tissue, I wasn't able to rely on any occlusal guides. And so I had to have custom cutting guides made with, of course, custom hardware to help position the bony segments accurately intraoperatively, such that I didn't have to rely on any splints, given the patient's inability to kind of accurately scan that, again, given his anatomy. And so I did gingivectomies at the time as well to uncover some of his teeth. And you can see his postoperative imaging here from where that custom hardware was placed. And here are some photos of him postoperatively. So significant improvement in his midface and mandibular projection. And intraorally, you can see now all of his teeth have been uncovered. And he has an occlusal setup that's still obviously not ideal, but he's getting ready to undergo some postoperative orthodontic treatment to try to settle things out a little bit more. But overall, really, really pleased with his result. And most importantly, he can lie flat at night. He doesn't obstruct anymore. And it's really been life-changing for him and his family. His mom used to sit there and listen to the pulse ox monitor overnight. And now she says she can sleep through the night because she doesn't worry about him obstructing. So really important changes. We can use the technology to really customize what we need to customize to help get accurate and predictable results. So this is another patient. She's a 15-year-old female, history of amelogenesis imperfecta. And so secondary to her underlying condition, she's unable to have any orthodontic appliances bonded to her teeth. She has midface deficiency, mandibular asymmetry, as you can appreciate here. And obviously dysmorphic teeth, again, related to our underlying diagnosis and kind of a complex situation. And here's her preoperative imaging, again, missing some teeth, and her teeth are relatively dysmorphic, some short roots. And so with that, we were able to treatment plan her for a segmental Lefort 1, BSSO advancement, genioplasty, and again, with the ability to create custom guides, custom hardware, and individualized surgical splints that really adapt to the patient's unique anatomy, we can achieve very predictable adults. And I should say, for most of my patients, I don't have to use this technology, but for the patients that really present with more complex problems, this is a really important tool to have in your toolbox. And here you can see 6 weeks postoperatively, I'm getting ready to remove her IMF screws, and this is where she lands. And obviously needs to work on her hygiene here, but overall a really nice change for her, given where she started. This next patient is a gentleman who was transferred to our level 1 trauma center, intubated, undergoing a recent cervical fusion. And you can see that hardware here. And he has a pretty complex mandible fracture, involves a symphysis, bilateral condylar necks and head fractures, and a pretty significant traumatic brain injury. And given the recent cervical fusion and the neurosurgical team's concerns, we opted to treat his condylar neck and head fractures in a closed fashion. We opened up the symphysis, plated that. But unfortunately, secondary to his brain injury, he was extremely combative and non-compliant in the postoperative period and was unable to tolerate elastics and instructions in that regard. And so developed a pretty significant malocclusion and malunion, really, of those bilateral condylar neck and head fractures. And so he actually underwent orthodontic preparation after about 1.5 years after his initial injury to try to correct his occlusal and skeletal situation once we kind of got a handle on the brain injury component of things. You can see he lost some teeth in the accident as well, but this is where he is prior to surgery. Pretty significant mandibular hypoplasia, or really secondary to his malunion of his bilateral condylar neck and head fractures. And so given his abnormal anatomy, I opted to treat him with inverted L osteotomies, again, utilizing custom bone plates and screws and cutting guides to help position these segments and get a predictable result in the setting of some complex movements here. And here you can see a CT scan before and after, obviously inverted L's in the bilateral mandible with bone grafting, and below are the images of where his custom plates were predicted to be and how they actually look. So this technology, of course, is extremely helpful for getting patients into the correct position when necessary. And here he is 3 weeks after surgery. So obviously still a little edematous, but significant improvement in his mandibular projection from where he started. And so let's look a little bit about how we can modify some of these osteotomies to treat patients, again, with more complex problems. So this is a patient in her 30s. She's a right unilateral cleft lip and palate patient. You can see that she has that residual cleft defect on the right side there. And she's actually undergone 4 separate attempts at bone graft reconstruction by various surgeons, and all have failed. And so she comes to me and she says, Dr. McGraw, what can you do to help me? I really want to have a tooth in my lateral incisor position, and I'm really sick of undergoing these procedures without success. And here you can see her intraoral shots. Obviously, again, she's got a pretty large residual defect there, some periodontal disease along the teeth immediately adjacent to the cleft. And here's her imaging. So again, pretty significant bony defect there. And so I said to her, I said, look, I don't think repeating your bone graft is really going to be a successful option given your age and the fact that you've had multiple failed bone grafts. So what I proposed to her is a modified Hemi-Lefort 1. I said, let's advance the right maxilla anteriorly to really cuspid substitute the lateral incisor with the canine surgically. And obviously I'll do a little bone grafting on top of that to help those segments form some union. But that way we don't have to worry about getting enough bone there to actually support either a dental implant or whatever she decides to do. And she was not interested in any sort of dental prosthetic options. And so here you can see her post-operative imaging. You can see I advanced just the right side of her maxilla anteriorly, bone grafted, which you can see she had good success on that coronal slice there. And here she is after she's healed. And she's starting some orthodontic treatment now just to help kind of detail things out, but she's extremely happy from where she is. Obviously the pre-existing periodontal disease continues to exist, but unlike before, now she has bone between the canine and the central incisor, whereas before she was lacking that. And here you can see again, before and after, and she's extremely thrilled with her results. So modifying the osteotomies is incredibly important for patients, again, with atypical problems. And then we can look at the timing of the operation. And so let's look at some surgery first cases. And I find that the surgery first cases tend to occur in patients that tend to be a little bit older. I think the conventional algorithm seems to be a little too rigid for a lot of them for various reasons. So this is a lady who came into the office for orthodontic surgery consult, opted to move forward with decompensation using clear aligners, and came back for an interval progress visit a couple weeks later after starting treatment, and said to me, Dr. McGraw, it turns out I'm kind of in a tough situation in my marriage. And ultimately I need to leave my husband, and he has my health insurance. I'm on his plan. And so what can we do in terms of moving forward with surgery? And so kind of unexpected, we decided to move forward with a surgery first approach. And here you can see our preoperative imaging, mandibular deficiency, aprotogonthia, obviously some AP deficiency as well in the maxilla. So I treatment planned her for a segmental Lefort 1 in 2 pieces for advancement, transverse expansion, BSSOs, and genioplasty. And this is where she landed after surgery. And this is at the time of IMF screw removal, so 6 weeks post-operatively. And this is where she started to where she is now. And so albeit the non-traditional approach in moving forward with surgery at that time, for her psychosocially, this was absolutely the right thing to do. Otherwise, she said, I don't know how I'm going to, stay married to my husband for another 8 months of decompensation prior to moving forward with surgery. These are all things that only really come out when a patient has trust in you, right? When you're able to build that rapport as their doctor and establish that relationship, suddenly they'll disclose to you what's really going on. And here's another example of that. So a patient, mandibular hypoplasia, opts to move forward with orthodontic surgery, sees the orthodontist, has fixed aligners placed. You can see her intraoral shots, and these are preoperative imaging. And she comes back for an interval progress visit, this time with her husband, and starts telling me, and I said, what's new? And her husband starts saying to me, well, I recently had my vasectomy reversed, and they want to start a family. And here she is, 39 years old. So we had to have a real conversation. She's had orthodontic appliances on for little over a month. And here we are having to talk about, well, what's the plan, right? And so she's someone I'm going to operate on this summer. But my point being is, if we didn't have that honest conversation about what her goals were in life, even though she was eager to move forward with surgery, the reality is starting a family and moving forward with orthodontic decompensation, that's a really tricky thing to navigate simultaneously. And so ultimately she opted to move forward with surgery first, which I think will be the right option for her. And let's look at early surgery. This is becoming an increasingly large part of my practice. I think, the psychosocial concerns a lot of these children are facing are very great. And it's not atypical for children that are 11, 12, 13 to be in my office in tears saying that they can't move forward, they need to move forward with some treatment because psychosocially they can't handle living with their dental facial deformity until they really reach skeletal maturity. So this is one of those kids. It's an 11-year-old boy. You can see mandibular hypoplasia, retrogenia, a little bit of AP deficiency of his maxilla too. Orally, you can see his photos here. Obviously, again, needs to work on his hygiene. Here's his preoperative imaging. And so we opted to treat him with BSSO advancement, genioplasty for advancement and lengthening. And again, even though at this point he's only 12 when we do his surgery, it's the right thing for him psychosocially. And you just have to have a really informed conversation with the parents and make sure they understand. And also, of course, the patient understands that there's some risk to moving forward with early surgery. But again, in my experience, this is becoming increasingly more common because patients are really struggling with how their dental facial deformity is affecting them in school and with their peers. And so here you can see that patient post-operatively, and again, where he started to where he is, and he's thrilled. And so even though, there's concern, of course, for ongoing growth and perhaps a little bit worsening of his occlusal situation, at the end of the day, this is a risk he and his family were willing to take, and an opportunity to really personalize treatment to the patient and not just throw them into the conventional algorithm and expect it to work and produce the results you want to see. And so with that, I would say that the conventional approach is rigid. It is well supported. And so these other different approaches and kind of personalizing care, you need to keep in mind that we need to be able to, of course, support these things from a literature standpoint. And the onus is on us as surgeons moving forward to really create that data so that we can support what we're doing. I think as surgeons, we're all pressed for time. We're really busy, but remember to ask the patient, what are their goals, right? What's their identity? What's their gender identity? What are their priorities in life, right? Health and social. These are becoming increasingly important. And we can customize orthodontic treatment, the surgical procedures themselves, and doing so, and even modifying timing, of course, to provide a patient-centric model of care. And so as I alluded to, I think the big future directions will be outcomes data. And I think also really having the ability to have accurate soft tissue predictions will really help facilitate this kind of pathway of really trying to, optimize every operation for the patient, because we'll be able to say to patients predictably, if we do these osteotomies, we'll be able to have this sort of change in a more predictable fashion. And so with that, I would like to thank everyone for the opportunity to speak today, and then I'm happy to take questions at the end.
Thank you, Dr. McGraw, for a very nice presentation. I would like to ask Dr. Ramirez to please introduce our next speaker, Mohammed.
Hey, Dr. Gali, thank you very much. It's a pleasure for me to introduce Dr. Mohammed Gamen from Egypt, presenting the topic short low sagittal ramus osteotomy, versatility of application. Welcome, doctor.
Hello, everyone. I do apologize again for the, for not being accurately in time. It's almost 3 after midnight in Egypt. And that's why it's, I had a problem with that. So I'm going to start with my presentation. Okay. Okay. Just to confirm, can you see my presentation?
We can see it. Thank you.
All right. Okay, so I'm going to give a talk today about the application of short low SRO. My name is Mohammed. I'm from Egypt, and I work among a very large family at Nasser Institute Hospital. And this is a conference we held a couple of years ago before the era of COVID, where we had a chance to have Professor Poznik and Professor Ranike doing an orthognathic surgery conference, which was very enlightening for all of us. And this is our OR department, Dr. Fahmi Abdul-Al, and this is Dr. Hamid Shaheen, Dr. Mamdouh, consultants, and myself here. We're operating multiple operations. I also work in a university in New Giza University among great colleagues and students, and as an examination supervisor. And those are my small team, where I always say that they can make anything impossible very possible. This talk is a part of an ongoing research about the application of the short low SRO, giving an introduction about that. No one can ever deny the huge contribution of and the originality of the technique described by Hugo Vergeser, the father of modern orthognathic surgery. I have to say that when in year 2017, I went to South Africa for a conference directed by Joan Ranike, and I met Professor Jeff Poznik over there. And I have to say that when he described his technique in doing the SRO, and he mentioned that he does the SRO below the lingula as a medial cut start, I had the impression that did he say that on purpose, or did he mistake himself for something? But a couple of years later, we're doing research about that. If we look at the evolution of the medial osteotomy, so the medial sagittal ramus osteotomy, described by Vergeser originally in year 1955, he used to go all the way around above the lingula, say at least 5 millimeters, and he would go all the way till the posterior border of the mandible. And then Hansek in 1968, he modified the medial osteotomy just to end just behind the lingula to give it a short cut, but still high cut. And the blue line would represent the direction described by Jeffrey Poznik in 2014, saying that he can do the osteotomy line on the medial side of the mandible just below the lingula in front of it. So the best introduction to this technique is by sharing the video. So can you see the videos? Okay. First of all, we'll just give some submucosal injection, and then of local anesthesia, just similar as the classic technique, doing a small cut.
We are not seeing the video, Dr. Ghanem.
You're not seeing the video.
All clear. Okay. Perfect.
All right. So first of all, now we're going to just give them local anesthesia, submucosal injections, like in a classic way. And then we're going to make a small incision. The small incision, I would say that in its upper part doesn't go downward directly to the bone, just, mucosal incision, maybe a little bit of cautery in the front part where the bone can be easily encountered. This is a part of the masseter muscle, can just, reflect it with a perosteal elevator. No need to cut it that much, because actually when you just, push it backwards and upwards, it goes away from your way. Okay. Then care now is getting to, exposing a very small part of the medial and lateral part of the mandible, just behind the last molar, Okay, so the exposure itself is considered to be minimally invasive. Here I'm using my J-stripper just to strip almost only 1 centimeter from the inferior border of the mandible, where I'm going to use it for the osteotomy line and just for the placement of the retractor. Care now is giving to the medial side of the mandible. If you notice that I did not strip upwards to the chronoid, I just, did 2 centimeter dissection here in this spot. Now I'm putting my Hagras retractor. The Hagras retractor is just placed in the 1 centimeter dissected by the J-stripper. And this particular video is done as a part of a research. So here we're using a cutting guide for the medial side of the mandible. I'm going to show afterwards how to do the cut without a guide. The guide was just used for research purposes. It's, it's not very important to use it. Okay, so I'm placing now medial retractor. I'm using a malleable retractor, and you can use whatever needed. I'm using the saw again to continue my cut. So this is the medial cut, and this is the horizontal cut connecting just in front to the second molar, between the first and second molar, according to the designed surgery movements. And I'm going to do the vertical cut on the buccal cortex. And this is, I'm going to give special instructions how to situate the saw to get the best outcomes. So this is how it would look like just behind the molar, just on the buccal cortex. I'm not going to use any mallet. I'm just going to wedge my chisel back there in the summit of the osteotomy till I had some sort of separation. As soon as I have any sort of separation, I'm going through the wedging action. I'm going to remove my channel or the inferior border retractor, and I'm going to continue the splitting without the use of any, inferior border channel or Hargus, because the inferior border retractors, they kind of keep the bone together. I would like to have zero resistance. This is the important moment where I wish you had the audio on where you can hear the click of the bone splitting. It's an important step here that every single time you're going to see the inferior alveolar nerve in this technique, so you have to be very careful looking for it. And as soon as you have the split, I would go and look immediately for any sharp bony spicules may endanger or injure the nerve during manipulation of the segments. So this should be taken into consideration. Okay, so this is how it will look like where you have the split. This is the nerve, even the vein with the nerve is intact, it was not injured. Okay, and according to your preference, I always do bicortical plating, bicortical screws, fix the proximal distal segments, and this is how we do it. Okay, and this is the final look of it. Okay, all right, good. Back to that presentation. Come back to the presentation now. All right, so giving more insight into where are you going to place your saw or your lineman there to do the cut. If you're doing a short high medial cut, there where you going to put your saw, but here, if you can notice, it's just below the lingula, okay, and it is directed to the angle of the mandible from the medial side. If we put it if we put this, slide from the buccal side, you will notice that this just all the drawing. Okay. You're reciprocating, so it would be directed, just toward the angle of the mandible, if you have the look from the outside, and this is how you should expect the direction to be. One of the most common, fears that this cut is going to endanger the nerve, but actually no. This area is very, very safe and it's very far away from the nerve, and it's less likely to cut the nerve unless you would like to cut the nerve. Okay, so if you even trace the cut, in the right side hand picture, the nerve is quite far away from the reciprocating, so it's quite safe to do so. So this is again the direction, because the direction everything, and maybe you can use a guide in the first couple of cases, or you can print the mandible and get oriented where the lingula is, when where the summit of the bone and direction of cutting. But after a couple of cases, I think that it's quite easy thing to do and not difficult at all. An important tip, I would say, that the angulation and direction of the cut, even on the buccal cortex. In this technique, the most common site of injury of the nerve is the buccal cortex area, front, not back there. This is the area where the nerve would be very near to the buccal cortex, and it may be injured or severed or even cut. So again, so this is where I would place normally the cocker, just 1 centimeter above the or at the same level of the lingula. As described in the technique, I do not expose the lingula at all. I don't need to look for it. Maybe in the first couple of cases I would do that, but after just doing a couple of 3-5 cases, you discover that no need for much dissection, and with less dissection, less muscle injury, more patient satisfaction, and less swellings. And yeah, okay. A very important tip as well is, where are you going to place your splitters? If you place a splitter front at the front, you may have buccal cortex unfavorable fracture. But if you put your splitter in the summit of the osteotomy, in the middle, in the thickest part of the bone, you are very, very less likely to have any kind of problems, and you can just see the nerve directly when you do the split. Again, so short high versus short low SRO. What is your fears? Why most of the people don't use this technique? Unique question when I spread it among my colleagues and mentors, because we're all originally educated that the medial cut, it has to be above the lingula. All right, so it's like we're genetically determined to do that. However, the technique is extremely simple and very versatile, and it can be done, in every case. Okay, so nerve injury. There is a very interesting research published by Cesarla 2020 to see that is it necessary to free the inferior abdomen from the proximal segment of the sagittal split osteotomy. And in his research, he found that no significant difference at all. There is no need to do that. And the nerve can accommodate any kind of movement without too much difference between the control group and the study group. And then I've seen Mike in his talk talking about the inadequate bony contact sometimes, and deflection between the proximal and distal segment, and how deflection may happen, and unequal or healthy seating of the segments may happen, and cause torquing of the condyles, with all the adverse effects of that. And the most common technique used, described by Ed Ellis 2007, is to do to do an osteotomy in the distal segment to accommodate the proximal segment, passively. However, an important paper cannot ever be ignored that published by Posnick in 2016, where he had 0 bad splits in a series of 5,024 sagittal ramus osteotomies. 0 bad splits, no problems at all, even in presence of third molars. And the most important thing that most of the patients were in 5 weeks were able to return to normal chewing diet and normal physical activity. Okay. All right, so I'm going to share a couple of cases about that. So this is our first patient. He is a patient with Marfan syndrome. He has severely atrophic mandible and a gummy smile. He had also a problem with his breathing. So his plan was to maximize the advancement of the mandible through complex anti-clockwise rotation and then advancement genioplasty. So this is our planned and post-operative CT superimposition. If we can see that we were able to advance his chin about 31 millimeters. His central incisor was advanced about 15 millimeters and an impaction of 11 millimeters. If you look at it, this is the 3D reconstruction of the plan, and this is what actually happened. When studying this case, if you look at his medial ramus, so this is a very, very thin ramus. How can you do a high cut here? If you do a high cut, if you just touch the area with your reciprocating, so you just have a bed split immediately without even using the splitters or anything. So his mandible is not for a high split osteotomy. It's a short low or any modification like an inverted L is the indication for the case. Okay, so this is the cut, and this is the nerve, and this is the fixation. And actually, we sometimes use a bone graft if you have a gap. You can take an autogenous bone graft or from any osteotomy from the maxilla or any part elsewhere, or even you can use an allogenic graft. So this is the patient a couple of weeks after surgery, and he had very good protrusion by maxillary advancement and proper orientation. And this is the patient before and after he took the braces, almost 1 year post-operatively. He has very stable bite and he has no problems at all. This is how his lateral surface looks like. You can even notice the great improvement of the airway and a lot of hardware. However, again, I don't use much of plates. I would like to use screws. So this is his panoramic X-ray before and after. And I guess this X-ray, I don't actually remember, but I guess this about 1 year afterwards. So this is another case where it's I would say one of the important indications that when you have asymmetry. So when you have asymmetry, and this patient we underwent maxillary osteotomy and mandibular base SRO and with genioplasty to correct his defect. And again, if we plan this case using a high cut, we'll have an interference on the left side. This interference would merit using either a piezo to cut a bone here or shave it or modifying the osteotomy. But if you use a short low osteotomy, you can see the difference. So on the short low medial cut, there's no much of interference at all. Whereas if it was planned as a short high medial cut, there would be a lot of interference in this place. So this patient post-operative photographs and occlusion, and he's quite happy, satisfied with no problems at all, with no manifestations of nerve injury or anything. Okay, so let me give you more indications of this case. Can you notice this patient and how she had very crooked mandibular curve of Spee? The curve of Spee refers when you cannot, you cannot plan this case easily. Let us take a look on her occlusion. So she has a completely scissor bite where her left molars, they touch the palate. Okay, so to totally roll this mandible and put it into proper occlusion, you will have massive interferences that's not easily to be resolved with classic techniques. Okay. So this is her plan, and this is the actual surgery done and the superimposition of it. And we have we can notice good accurate results. So again, if you plan classic osteotomy lines, this is what you're going to see. Okay, you're having massive interferences. One of the other options is actually mandibular body osteotomy. Okay, it's just to avoid the total collapse of segments into each other and make it very, very difficult to manage. So if we implement the short-low SRO, this is what we have. This is actually here post-operative 3D reconstructed image where you have the proximal distal segments all together and all sorted, and everything is fine and the patient is fine. So this is her right side. We had to use allogenic bone graft to fill the gap, and this is her left side seated nicely, and this is the patient post-operatively, and this is her occlusion after taking off the braces, and she's currently doing some sort of mouth rehabilitation. This is the patient before and after. Oh yeah, maybe the left canine is a little bit popping out, but he's quite satisfied about the results. This is his X-ray, her X-ray, and yeah. Okay, again, another indications of this patient, severe facial asymmetry post-operative ankylosing pathology. The patient actually has a very wide range of movement, and she best candidate for total joint reconstruction. However, due to many reasons, she wouldn't like to do a joint reconstruction. So we just planned a classic orthognathic surgery in the current situation. This is what we have. So we planned, again, short-low medial cuts, and we had 0 interferences, and we were able to move the mandible 3D movement and have safe results. This is the plan, and this is the result. And yes, we can see here superimposition, good results. The planning is almost done. And this is the patient post-operative, and this is the patient 1 year post-operatively. Maybe she needs a peak implant or anatomic patient-specific implant on the left side of her face. However, she's having good occlusion, and the occlusion on the top of the side is before, and this is after 1 year. So yeah, she's satisfied and she's happy. Maybe some dental rehabilitation will benefit her to improve her bite more and more, but the patient has no problem chewing at all. Okay. So, of course, there is no procedure without any risk at all. And I would say that, of course, a nerve may be injured and even cut, and proximal segment may have problems. And a complex surgery would be in a case of wisdom in the osteotomy line. So one of the cases I had, we've almost done around 100 cases, let me say 120 SROs. So we had 3 nerve injuries. 2 of them was a total nerve cut, and the nerve was cut actually during the bone separation, not the osteotomy. So when we had the splitting, and you cannot see the nerve. Proximal and distal stump of the nerve were identified, sutured together, and then fixing the proximal distal segment with the usual bicortical plates. And this patient actually, she visited our practice yesterday, and she does not complain much of numbness on the left side. So as soon as you have the cut, it is the best chance to repair the nerve. If you repair it immediately, you would have better results. Buccal shelf fracture. Sometimes it happens, and I would say that #1 reason for fracturing this segment is we sometimes challenge ourselves to time it down to maybe 3 minutes or 4 minutes osteotomy. So we've classically do it over 7 minutes, 7 minutes per side from the exposure to splitting. If you would like to make things fast and you think that you master it and no problems may happen, you may have this problem. However, we're able to put just the piece back and put a couple of screws over it, and I'm sorry, not have the X-ray for it, but the patient's doing fine, and she doesn't have any problems in fixation. One of the problems, of course, that would decrease the bone contact if you have a wisdom tooth in this part. But again, you can safely remove the wisdom tooth and fix the area. If you don't have enough bone for bicortical plates, bicortical screws, you can just put a plate and have a good stump of bone fixation as well. Okay, so my conclusion, and it's an invitation for everyone listening to this talk, that short loads are always an important tool an orthognathic surgeon has to master, because you will face and you will see those indications, and I'm quite sure that every one of us would see those indications, and you need to modify your technique to get good results. And I have to thank Professor Posnick for supervising all this work and his deep discussions and initiation of this project. My gratitude for all my family and my friends and my colleagues. Again, I'm very sorry. Today we were at the Nasra Institute and we had a long, busy day operation. So however, I'm happy that I made it, and I would like to end with a quote for Albert Einstein, that it takes a touch of genius and a lot of courage to move in the opposite direction. Thank you, everyone. And if you have any questions at all, you can just email me or ask me any questions. And I'll be waiting for the discussion to receive questions, and happy to share my answers.
Thank you, Mohammed. Wonderful presentation. Our next speaker will be Dr. Rodolfo Asensio Guerrero from Guatemala. The topic will be orthognathic surgery in cleft lip and palate patients. Thank you. You there, Rodolfo?
Yes. Hello. Good evening. Let me start. Okay. Good evening to everyone. Thank you. Thank you to Janos and Lasibu for this opportunity. Our work. We are going to, I'm from Guatemala. We from the Centro Infantil de Estomatología. We are a cleft center for 66 years. So we are going to start orthognathic surgery in cleft patients. First of all, we have to remind that there is a multidisciplinary treatment. The surgeons, the pediatricians, the orthopedics, orthodontics, speech therapy, nursing. We have to keep this always in mind. This is our story in Spanish. Our protocol starts with the cleft lip surgery at the age of 2.5 months. After that, we do the cleft palate at the age of 2 years. But the important thing is the orthopedics and orthodontics moment of stage of protocol. We have to diagnose the patients at the age of 4 years old, if they have a crossbite anterior or posterior, and we have to apply orthodontics to get into the patient for the cleft, for the bone graft, the cleft alveolar.
Dr. Asensio, can you hear me? Dr. Asensio, can you hear me?
This is a very important stage. Yes, yes, yes. Vale, ya entendí.
Dr. Gonzalez, is that you speaking?
Yes, Professor. It's just that he has the Spanish button. That is why my translation was bothering him while he was giving his lecture. So I just asked him to change the channel into English. That way he won't listen to me.
Okay.
Thank you.
Ready. I'm gonna repeat from here. It's okay?
Go ahead, please.
Okay. So this is our protocol. Sorry, it's in Spanish. We start the cleft lip surgery at the age of 2.5 months. The cleft palate, we do it around the 2 years old. And then we are going to see the patient. We will follow up the patient until the 4 years old. This is a very crucial stage of the protocol because it's going to start the orthopedics and orthodontics treatment. We have to diagnose the patients if they have a crossbite, anterior, posterior, or both of them. Then we are going to move to the orthodontics, and then we are going to see some patients. So the orthodontics and orthopedics and alveolar graft, this is a very, very, very important stage of the protocol, as we said. So if we have a good protocol, is the orthognathic necessary for all the cleft lip patients? It has to be a part of the protocol all the time. We don't think so in our protocol. We think we can avoid the orthognathic surgery or destruction of the craniofacial destruction. So we are going to start with the orthodontics and orthopedics with a Sensius method. We are going to be supported by devices for transversal expansion of the maxilla and protraction with the face mask. We are going to make examples with cases. This is our first case. This is a 4 years old child. He already been diagnosed with cross bites. He already used the expansion and protraction with the mask and the Hyrax. Then he came to us to prepare the patient with orthodontics to the bone graft of the cleft alveolar. This is the first time we see the patient. This is the preparation for the bone graft, and this is the result we obtained, the arc we obtained after all this, the orthodontics and orthopedics and the bone graft. This is the patient prepared for the bone graft, the alveolar bone graft. And the important thing about this is to make a very, very good relation, maxillomandibular relation. This is the time of the bone graft, as you can see. This is an evolution since the cleft alveolar until the eruption of the canine, the bone graft. As you can see, this is the evolution of the patient, and you can see the stable occlusion after this orthodontics and orthopedics. This is also the evolution, and this is the patient at the age of 9 years old, and you can see the good occlusional plane and the stable occlusion of the patient. This is the second case. This is a 4 years old also patient. As you can see, is with a crossbite anterior and posterior. So we have to do orthodontics, orthopedics with a expansion, transversal expansion and protraction of the maxilla. After that, we are going to start with the orthodontics to prepare the patient for the bone graft, as you can see. What is the goals of the bone graft is to consolidate the segment of the maxilla and also to close the fistula, the nasal fistula, and make a way to eruption, the canine eruption to the mouth. As you can see in this picture, this is the final result of the arc of the maxilla after all the orthopedics, orthodontics, and the bone graft. You can see this is the patient at the age of 9 years old, 11 years old, at 16 years old. And this is the different photos of the patient. As you can see the stable occlusion of this patient, the profile at the age of 16 years old, avoiding in these times, in these patients, the orthognathic surgery as part of the protocol for management of the cleft lip patients. This is the evolution since the patient will receive at the age of 4, and this is the final result at the 16 years old patients. So we believe it is possible. We have been working with this protocol for 16, 18 years. So we avoid the orthognathic or distractions in these patients. Less than 2% of the patients are going to orthognathic surgery. This is the final occlusion, the final presentation of the maxilla. Always, as you know, not all the patients have a good follow-up orthodontics, or they left the our protocols. So we have different approaches to solve these patients. They're coming patients from other centers with several intervention in the lip and the maxilla, in the cleft. So we are going to present this maxillary transportation. Bone transportation is an approach that we can use on this patient. This patient is 19 years old. He came with us with several surgeries in the cleft lip, several surgeries in the cleft palate. So she didn't go to the orthopedics or orthodontics treatment. So we have to prepare the patient. As you can see, when we prepare and make a good relation, a crucial relation, we can see the big gap of the cleft alveolar is around 12 or 13 millimeters gap. So we have to prepare the patient. As you can see, the big fistula, was very big, very big. So we prepare the patient, and what we have to do here, we can do a bone graft. We have to do another techniques. We don't have soft tissue to cover it. So we are going to use a distraction or bone transportation. As you can see, this is the osteotomy. After we put the distractions, these devices, and we obtain this. This is the around 13 millimeters gap, and we obtain after the bone transportation of 5 millimeters gap. So in this time, we can close the fistula and we can do the bone graft, obtaining a good result. And after this, we are going to continue with the orthodontics, obtaining this profile in the patients. This is a profile in the patient. You can see we have a good relation, a maxillomandibular relation, a good stable occlusion, and a good profile of the patient. So in this case, again, we can avoid the big surgeries of these patients. Also, we have patients of orthognathic surgery, of course. All 2% left our protocol or came from other centers. So the orthognathic surgery is, this is a patient that came for us with several surgeries also, but it's important to individualize every patient, not all the patient candidates for orthognathic surgery, because with several surgeries in the palate, the blood supplies could be compromised, or the alveolar pharyngeal function, it can be compromised also. So in the time you can do an orthognathic surgery with advance of 7-8 millimeters, we have to use another approaches like a craniofacial distraction. In this case, it is possible to do an orthognathic surgery. We advance around 7 millimeters and make a setback of the patient, of the mandible of 3 or 4 millimeters, as you can see. But also there is another important thing about the orthognathic in cleft lip. We have to decide, because most of the patients doesn't have a bone graft. So we can do the bone graft before the orthognathic surgery. We have to wait around 1 year to stabilize those segments, or we can do, as Dr. Posnick described, we can approximate the segments of the maxilla when the gap is no more than 1 centimeter. We can approximate, and we have to close the fistula, the nasal fistula during the surgery. In this case, we did the bone graft first. We wait around 1 year for the stabilization of the segment of the maxilla, and we obtain these results. So this is the result of the surgery. This is one year approximately after surgery. So it's possible, but we have to take good decisions to make this orthognathic surgery in cleft lip patients. Also, we have patients that they couldn't have a standard orthognathic surgery, so we have to make an approach with this craniofacial distractions. I'm going to present this patient. This patient will have multiple surgeries in the cleft palate. As you can see, with the big constrictions on the maxilla and the posterior and transversal constriction of it. So if we advance or we expand this maxilla, the blood supply can be compromised. So we decide to make a partial destruction. As you can see, we were planning this patient. We plan guide cuts, surgical guides for the highly formed through the zygoma, as you can see, and we played subnasale to make an attraction of the middle face. It's around 1 millimeter per day. We use a red device for making this traction. This is the patient. This is the patient 15 years post-op. As you can see, we advance around 15 millimeters, and we expand the transversal span of the maxilla around 11, 12 millimeters. So the change is very good. This is the patient, and right now he's going to continue with the orthodontics, and all the patients have to stay with the red device around 8 and 9 weeks for the consolidation of the maxilla. So the conclusions are: we can avoid the orthognathic surgery in patients. The orthognathic or destruction, it doesn't have to be a must in all the patients. So the cleft patients, we can avoid the surgeries with a good orthodontics protocol. We have to individualize every patient measurement of this patient with cleft lip, and the important thing is to know that the multidisciplinary treatment of this patient. Thank you very much.
Excellent, Rodolfo. Excellent talk. Dr. Ramirez will introduce our final speaker, followed by a question and answer. Dr. Ramirez, thank you.
Thank you so much, Dr. Gali. It's an honor to present our last speaker, Dr. Jose Antonio Garcia Piña from Mexico, with the topic Adjunctive Procedures to Enhance Orthognathic Surgery Results. Welcome, Dr. Garcia.
Hello, Dr. Ramirez. Hello to everybody. Good morning, good afternoon, and good evening from wherever you're listening to us. So it's a pleasure for me to share with you this topic. I named it Adjunctive Procedures to Enhance Orthognathic Surgery Results. So the main objective of the procedure is that as orthognathic surgeons, sometimes we miss these 4 corners, or we miss what will happen with these 4 corners after our orthognathic surgery procedure. One of the objectives is to show some diagnostic.
Jose, excuse me, are you sharing your screen? It is not showing.
Oh yeah, sorry about that.
I love to look at you, but I prefer to see your screen.
Thank you, Doctor. Sorry for that one. Yeah.
No,
I think I'm already sharing it, right? Are you able to see it now? Yeah.
All clear, doctor. Yes.
Oh, perfect. So I was saying that as orthognathic surgeons, sometimes we miss what will happen with these 4 corners after our orthognathic surgery procedure. So one of the objectives is to give some diagnostic criteria in order to learn what to do and when to do it with the zygomatic projection and with the mandibular angles in some facial symmetries or in our orthognathic surgery patients. The other objective is to show some cases with the nose, with the rhinoplasty, doing it in a single stage with orthognathic surgery, and some of the tips, technical tips I can give in order to my little experience in this topic. So the first paper I would recommend for you to read is this paper of Dr. Maurice Myers, who explains what about the angle in the mandibular in the male patient, the mandibular angle with the male patient. So he defines, after making some questions to some surgeons and some patients, these angulations and these measurements that the mandibular angle should have. And this will be taken into consideration with those patients that are looking forward to have more volume in the mandibular angle. So one of them is that we first have to measure the interzygomatic distance. And then we have to calculate the 90% of this distance should be our distance of the intergonial angle. And this has to be measured in the CT scan as well. So this is one of the tips in order to design the implant with a 3D specific implant. The other angulation that has been taken into consideration is that the gonial angle should measure 130 degrees. So this is another consideration in order to perform the 3D patient-specific implant. And in a vertical height, the mandibular angle in a male patient should be in a shaded area that's located between the commissure of the lips and the lower border of the lower lip. So we should be using these measurements in order to design our implants. Now, I am using right now PEEK, polyethylethyl ketone. It's a biocompatible material. It doesn't osseointegrate, so you will need to fixate it with some screws, with some titanium screws, but they are easy to remove in order if they have some failure. You know, this paper of Dr. Sergio Late, he describes that they save time in order to make PEEK-based patient-specific implants as compared with the porous polyethylene stock implants. And they are easier to use, they reduce operating time, and they create more symmetry as compared with the porous polyethylene stock implants. So what about the zygoma? We know from the profile view, if we make a vertical line in the anterior border of the cornea, we should see the zygomatic prominence 2 millimeters ahead of this line. If we see it beneath or behind this line, we will be needing to add some volume in this area. We can use fat grafting, we can use implants, we can use patient-specific implants, we can use stock implants as well. And some of our patients, even if they are class 2 or class 3 patients, have some kind of relapse in the malar area as well because of the facial development of the dentofacial patients. We also know that the globe with a poor support will look prominent, will look with proptosis, and we will look a flat face in these kind of patients with malar or zygomatic deficiencies. So what about the fat grafting? I always like in my orthognathic surgery patients to have some fat grafting. I usually take it from the abdomen. It's just technically speaking, it's a simple operation, but the difficulty of the procedure is that as a surgeon, you have to calculate the relapse or the resorption that your fat graft will take place. So usually in the papers, we say about 60% will be lost in the first 6 months, but then the fat cells that will be living in the new area, they will stay there forever. So we have to exaggerate with our fat grafting in our orthognathic surgery patients. There have been some papers from Dr. Raffaini, some papers from Dr. Derek Steinbacher, and they also say that fat grafting also helps in postoperative edema after orthognathic surgery. So I usually take it after some infiltration of tumescent solution in the abdomen, and then make some little incisions, periumbilical incisions, and take it with a cannula and a 20 cc syringe. Then I usually leave it in a decantation for 10 minutes, and then just separate everything in order to have just the fat cells. And that's what I use. I usually don't centrifugate them. And then I just inject it, having in mind that 60% of the volume will be lost. This is a good chapter in aesthetic orthognathic surgery and rhinoplasty in this book, 2019, Fat Grafting. And it says where sites can be used, you know, mandibular border, malar area, labiomental crease after a big chin advancement, zygomatic arch, lips, or nasal labial groups. And this is the recommendation of how many cc's according to the author. Okay. So what about the nose? This is a new chapter, just came out from the oven recently of our friend Dr. Abraham Montes de Oca. And he says that it is a good procedure to make rhinoplasty simultaneously in orthognathic surgery patients. What I have experienced in my own experience is that I like to do it simultaneously as always as I can. When the orthognathic surgery, I always do first the orthognathic surgery, of course, and I like to use, and I like to make a change of tubes. So in the beginning, the patient is with a nasal tube in order for me to finish the orthognathic surgery. And after that, I change the tube from the nasal intubation to the oral intubation. The anesthesiologist does that, of course. And then I finish with the nose. What other things have made my rhinoplasty faster? Whenever I make the down fracture, I like to take the septum cartilage, the lower border of the septum cartilage, and use that as my graft in order to finish my nose procedure. That will save you time whenever you're making the nose. The other thing is that I like to use the cinch in order to reduce the alars, but I also like to, it depends on the case, but I also like to use the alaroplasty or alar-based reduction in the rhinoplasty. So the advantages is that it is only a single procedure, it has cost reduction, an earlier final result, faster return to work and daily activities. The disadvantages is that it is a longer procedure, more edema, poor predictability in inexperienced hands, because as a surgeon, you should understand what changes will be happening to the nose after the Lefort. Complications are inherent to each procedure, difficulty to extubate and to intubate, possibility of non-favorable nasal results with inexperienced surgeons, and whenever a complex nasal surgery, a severe facial asymmetry, or complex orthognathic cases, it is necessary to perform in a second stage. So let's have some cases. This is a case one. This is a patient with a class 3 malocclusion, nasal hump, poor nasal tip definition, poor malar projection. This is the preoperative occlusion of this patient, the virtual surgery planning. And then we have this diagnosis: long mandibular ramus with steep mandibular occlusal plane, severe maxillary deficiency with a flat occlusal plane, chin deficiency, cheekbone deficiency, ear asymmetry. The left ear is bigger than the right one. Nasal hump, poor nasal tip projection, and poor nasal tip definition. Our treatment objectives are orthognathic surgery with chin advancement, fat grafting to the cheekbone area, left otoplasty, and rhinoplasty. So this is the patient 4 months postoperative. I really had to make a big volume in this area. I'm still calculating, it will resolve a little bit more. We are in a 4-month postoperative course. We have created a better nasal profile, a better facial profile as well. In the frontal view, I have created more symmetry in the ear area, and I have also created more volume in the cheekbone area with my fat grafting. This is the other profile view, just showing a better facial aesthetics as well. And this is the smiling position of the patient. This was done in a single stage procedure. So sometimes as a surgeon, one must understand that if you are very tired in the orthognathic surgery, you must defer the rhinoplasty in a second procedure, and the patient should know that. Because if there is a bleeding, if there is a complication, if there is a bad split, if there is something else against your orthognathic surgery, you will be really, really tired in order to do the nose. This is a second case, female patient, 26-year-old, This is the frontal view. Now we have, this is an old case. It was done around 7 years ago. Long condyles. This is a preoperative intraoral view. Long mandibular rams with deep mandibular occlusal plane, vertical chin excess, cheekbone deficiency, protruding ears, nasal hump, poor nasal tip projection, and poor nasal tip definition. The treatment was BSSO with chin reduction and advancement, vertical chin reduction and advancement, cheekbone stuck implants. In this patient, I use stuck implants, autoplasty and rhinoplasty. So my preference so far has been using implants. I really believe that in the future, thinking in a 30-year long-term stability of my cheekbone area, it will be more advantageous in order if we use implants. So, but it also depends the economy of the patient. Sometimes the patient doesn't have that enough in order to cost these implants in the cheekbone area, and sometimes I have to use fat grafting as well. So this is the 1 year postoperative view with the cheekbone implants, orthognathic surgery, vertical chin reduction, autoplasty and rhinoplasty in a single stage procedure. We can look at a better facial contour. This is the facial postoperative pictures. We can see the nasal hump reduction, better tip definition, better tip projection. Now, this is the final occlusion. So this is an asymmetry case. This is a reorthognatic surgery. And whenever I have an asymmetry case, I always ask to the patient, which side of your face do you like the most? This is a powerful question because as a surgeon, this will help me to understand what to do. If the patient decides that this part of the face he likes the most, I need to do some reduction in this part of the face. And in the inverse, if the patient likes this part of the face, I need to make some augmentation in this part of the face. So this patient liked more this part of the face. And we can see there is a maxillary canting. We can see a chin deviation from the midline. We can see posterior crossbite as well. Now, this patient already had orthognatics before and was fixated with bicortical screws. They only touch the mandible, and he will need a bimaxillary surgery with some adjunctive procedures in order to enhance the facial aesthetics. So what do we do? Re-BSSO, bimaxillary surgery, surgery only, surgery first, no orthodontics involved, chin advancement, chin centering and shaving, neck liposuction, right buccal fat removal, because I'm planning to remove this volume, ostectomy and removal of the right mandibular angle, and I do it after the BSSO, right facial liposuction, and 20 units of botulinum toxin to the right masseter. So this is the, sorry for that one, this is some videos showing some of the virtual planning, some intraoperative pictures. Remember, whenever we have an asymmetry, we need to make this technique. Dr. Lung already talked about it in the first lecture. So this is a patient 1.5 years post-operative with a very facial symmetry. I almost got it as the left side because he liked more the left side of his face. So a little bit of chin deviation, maybe 1 millimeter. That was like my mistake, but the patient's very happy. I'm very happy with the result. So whenever I remove the mandibular angle of the patient, sorry for that one, just let me run it again. Just it closed, sorry for that one. So I'm waiting for it to open. Okay. So I was saying that when I make a lower border ostectomy of the proximal segment, I usually do it after the BSSO is splitted. Once it's splitted, I just pull through the intraoral approach this segment, and I make the lower border ostectomy and remove this piece of bone. That's just like a technical note. So this is a patient. Now let's have some other cases and finish with the conclusions. So this is a patient with a severe facial asymmetry, severe maxillary canting. And again, powerful question, which side of the face do you like the most? And she answered, none of them. I would like to have less volume in this area, but more volume in this area. And this is a reorthognatic case of mine. She was a really hard case for me. It was done under surgical first protocol. She was full of veneers, upper and lower denture, bruxism, no cusps in the molars. I had to make twice the orthognathic surgery, but I'm very happy with the result, and she's as well. So we can see the severe maxillary canting. She also had anterior-posterior maxillomandibular deficiency and a chin deficiency as well. This is the preoperative CT scan of the patient. So in order to balance what she asked for me, I make a lower border ostectomy of this area, but I fat graft this side of her face. So the treatment was Bimax surgery only, surgery first, plus chin advancement, chin centering and shaving, ostectomy removal of left mandibular angle, facial lipotransfer to her right face, right angle, and right mandible. This is the pre and the post-op CT scan of the patient. And we can see the better Frankfurt with the occlusal plane relation and better anterior-posterior relation of the maxillary bones. This is 6 months post-operative after the second intervention. And you can see an almost perfect symmetry in this case, with some more volume in this area, less volume in this area as well, better canting, better midline. The patient's very happy in a relaxed position as well, symmetry in this area. And then this is a patient in her 3/4 view. Okay, the other 3/4 view of the patient. We can see the profile view with a better chin-lip relationship and a better chin projection and a better chin to neck position, distance. So case number 5, we will see some PIC implants, mandibular PIC implants. This is a male patient, 30-year-old male patient who wants some mandibular angles. He already had some chin implant in this area, silicone chin implant. It's a little bit diagonal, a little bit asymmetric. He has had some fillers in this area as well, a previous rhinoplasty as well. So he desired to look just as Justin Bieber. So what we made is just place the CT scan in a profile view with a Justin Bieber picture and just add the volume with an engineer, having in mind those measurements we talked about in the beginning of the lecture. So the other thing that we did, it was just a chin box advancement, or a square form, a square shape. This technique is an old technique, was published since 1985 for the first time, and has had some modifications. The advantages I see is that you make, this was on 2007, 2017, it was named Geniopoly, 2015, oblique sagittal split sliding genioplasty, 2018, mentoplastia sagittal curva modificada, and 2021, telescopic genioplasty. So what are the advantages of this concept? The advantages is that we're going to look at a narrower chin. It is indicated when you want to look at a narrower chin. We can see the mandibular angles in a better position if we compared with the lower lip, as mentioned in the initial paper. We talked about it. The patient's happy about it. I also made some hyaluronic acid injection in the glabella area because he wanted a straight line in the frontal area. And we can see the mandibular angle definition with the custom PIC implants. So last case, in order to finish, one good maneuver in order when we are inserting the custom PIC implant is to make a big dissection of the masseter muscle, and we have to dissect the pterygomasseteric sling completely. Otherwise, you will have problems inserting those implants. So this is a last patient, 20-year-old male patient. He has a canting of the occlusal plane. He didn't want orthognatic surgery. He has a chin deviation according to the midline of the face that is pointing to his left side. And what we planned, he also wanted a symmetric mandible, but he wanted more angles. So what we planned was an asymmetric custom PIC angles and an asymmetric movement of the chin to locate it in the middle of his face, not in the middle of his maxilla, not in the middle of his mandible, but in the middle of his face. So in order to do so, we created some cutting guides and positioning guides in order to make the cuts as planned. We prevent the plates. I still don't use the technology of 3D printing the plates, but these are the intraoperative pictures of the cutting guides and the positioning guides of the chin. And here we can see a 4-month post-operative look with a very facial symmetry and centering of the chin area. The implants are making a better jaw angle, and well, the patient's happy. I have here a little concavity in this area that should be addressed during the surgery, either shaving the implant or either placing some fat grafting or some volume in this area. So conclusions, adjuncting procedures are powerful tools in order to enhance facial contour and results in our orthognathic surgery patients. We should be thinking in these multiple treatment options that we might offer in order to enhance facial aesthetics in the orthognathic surgery patient. Thank you very much. I'm in Mexico and this is my place, and you're welcome whenever you want to come. Thank you.
Thank you very much, Jose. Can everyone hear me? Yeah. We're going to proceed into the question and answer, and I believe we have just enough time for one question. We had quite a few questions submitted, but we'll start with Mike. You've been waiting the longest, Mike. Thank you. How do you like, in your practice, how do you like to manage third molars with the BSSROs? Do you like to take them out ahead of time? Do you like to wait? I know you touched upon it a little bit, but could you give us your protocol in your practice?
Well, thanks, Professor Gali. If we have time, like conventional orthognathic planning, we will pick it out if there is an impactive third molar, because we have to wait for the orthodontics anyway. But about 50% of my cases are doing surgery first. So in those cases, I'll just go ahead and take it out during the surgery.
Great. And when you do take it out, did you mention how long ahead of time do you like to take it out before the sagittal split?
It doesn't really matter. I think 3 months is a good timing, just for the bone to heal initially.
Okay, thank you. We have a question for Dr. Klaus from Maria Fernanda. How do you manage impactions of the maxilla where you have to remove posterior bone in the minimally invasive surgical technique?
So we receive a lot of questions regarding to the surgical technique and some difficulties because of the incision and the direct vision. One of the biggest challenge is the posterior impaction. So we don't have any trouble with larger advancements, with inferior repositionings. The problem is we also don't have problem if you need to manage the nose with turbinectomy or something, or anterior impaction. The only problem is posterior impaction. So in the past, I would prefer, in the past, with conventional surgery, I would prefer to remove the bone interference during the vertical reposition, trying to find the exact spot where we couldn't move the maxilla upwards. But now with a small approach, I don't have this option. So I just see the virtual planning where I need to remove the bone, and I go kind of aggressive. I remove it all to perform the impaction. So if, for example, a 4 millimeters impaction, I'm going to remove 4 or 5 millimeters prior to try to move the maxilla. And but the difficulty, the challenge is only in the posterior area.
Okay, thank you. Dr. McGraw, a question from Peter in Australia. How important is the psychosocial assessment in orthognathic patients in particular, obviously in any patient, but is that assessment, does it include the orthodontist as well? Does it include the parents of the patient? What, in your experience, how important is that, and how do you manage the psychosocial issues?
I think it's incredibly important, and the literature really shows it's really the psychological view of the family and the patient in terms of how successful the surgery is, right? So even in planning these operations and how we're going to do them, you have to consider where the patient is starting, because that's going to influence obviously the success of the surgery to some extent. Even if you think you've done a terrific job and you have a beautiful result, that really plays a role, and that's been really demonstrated in the literature. So I think it's tricky because time is of the essence for all of us, and with my jaw surgery consults, I already spend about an hour with them, so it's a long visit, and trying to, depending on the patient, understand the degree to which their deformity is influencing them psychosocially can be very challenging. Some people are very outright with that information. Others seem to be a little bit more nervous about disclosing that. And so that's actually one of the reasons I really like to see patients back for a second kind of follow-up interval progress visit. But it remains very challenging. I don't usually find that my orthodontic colleagues are able to provide me much information in that regard. I think some of the challenges they face, at least here in the US, is that the option of discussing surgery with families is often met with some resistance. And so they kind of focus more on getting over that barrier to encourage them to even come in and have a surgical consult. And I think they have a little bit less insight into some of the psychosocial concerns from the bony deformity standpoint.
All right. Great answer. Thank you. Dr. Alawatri from China has a question for Mohammed. Very nice talk, Mohammed. How do you manage mandibular setbacks using this low, short approach? And is there, in your experience, any added risk to the lingual nerve based upon the approach that you described?
And that's a very, very good question, and directly into the point. The essence of this technique, the main, I wouldn't say a trick, but the main principle of doing it is to maintain good buccal bony contact. Okay, so you have to plan it first. So if you're going to advance the mandible, or you're going to sit back the mandible, you need to make a decision on the amount of bony contact. So I'm going to say first, if you're going to advance the mandible, you will have to extend the vertical front cut, maybe till the mental foramen. Okay, you may need to have to do that to have good bony contact. Okay, if you're going to set the mandible back, I think this is one of the best techniques. If you think about it, you know, the mandibular, the sling, the tergomacetic sling. If you're going to set back a mandible, the less you touch and manipulate this area, the better result you're going to have in terms of relapse, in terms of, you know, ease of setting back, things like that. So I think for setting back the mandible, it's quite an easy go. Yeah, you know, you just don't have to extend that buccal cortex extension, the vertical buccal extension that much front. You're going just to do a classic cut, where you're going to end between, you know, just distal to your first wisdom. And when you're going to sit back the mandible, you're going to remove a little bit of bone on the buccal cortex. No need to touch the lingual part. The second question about the lingual nerve, yes, very good answer, because very good question, because actually the first nerve you're going to see is the lingual nerve, and mostly you're going to see it of maybe in 99 of the cases. However, there is nothing subperiosteal. The only thing subperiosteal is the bone. Okay, so if you keep a good envelope, a periosteal envelope, you're not going to injure anything. The injury comes from the retraction, basically, you know, too much retraction. So you have to be careful. You don't need to do much of lingual retraction. You don't need to reach the inferior border from the lingual side, you know, just, you know, a matter of 1 centimeter or something like that. And the splitting is going to happen by itself, because this area is inherently weak. Okay, so I hope this answers your question.
Thank you for your answer. Rodolfo, we have a question here from several different people, but when do you decide to use distraction versus traditional orthognathic surgery in the management of the orthognathic surgery in cleft patients? And when you do choose distraction, when do you decide to use internal versus external distraction? Yeah, you want to unmute yourself, Rodolfo? Yeah.
Thank you for the question. I decide to use distraction or orthognathic surgery when the patient comes to our center. We have to evaluate the patient individually, every patient. Sometimes the patients from outside have 6-7 interventions in the palate for different techniques. So the blood supply is compromised. They open the mouth, and the palate get white directly. So we have to check if we make an advance of 7 millimeters, we are going to compromise the blood supplies of the maxilla. Also, for the contraction of the maxilla, the contraction of the maxilla, the insufficiency velopharyngeal, it can be a very important thing to evaluate to make an orthognathic surgery. In these cases, we decide to use the craniofacial distraction. This is the main point of these patients. Also, as you see in the last case, it was really very difficult to use a traditional orthognathic. We have to go directly to the distractions. I think that resolves your question.
Thank you for your answer, Rodolfo. Nice job. Jose, the last question we have is, why do you, this is from Maria Fernanda, why do you prefer malar implants in some cases instead of doing a high Lefort 1 osteotomy?
Yes, so that's a good question. So usually the patient has to have a 1-to-1 relationship in the AP deficiency of the maxilla and the AP deficiency of the zygomatic bone. That should be like my main indication when to do that. The other thing is that in my hands, it is easier to place the implant and fixate it as compared to make a high effort one. Whenever I make some clockwise or counterclockwise rotations as well, even if I am making a 3-segment Lefort or 2-segment Lefort, will be technically speaking more difficult. So in my hands, I rather to place implants. It's just like a surgeon's preference, and it has to be based in which case should be objectively used. Yeah.
Thank you. Thank you for the answer. Dr. Ramirez, would you like to make any comments?
So I am really happy to this opportunity. Thank you, IAMS, Alasibu. It was a pleasure.
Yes, and I want to thank as well Dr. Ramirez for being the co-moderator and all of the wonderful speakers today. These are very difficult topics, but this is an area where oral and maxillofacial surgery actually owns this area of orthognathic surgery, and we own it because of the research that many of our forefathers have done in this area, and some have been mentioned tonight and some haven't been mentioned. So I want to thank everyone and congratulate everyone for wonderful presentations. I want to thank the audience. I want to thank Kimberly and Xander for the help that you guys have provided, and thank you very much. And this concludes our discussion today. And Xander, do you have anything you want to add? That it's available on recording for those of you that were unable to attend live?
Yes, so, Doctor. I'll close it out like Rod Serling. Not a problem.
You do it.
This concludes day 3 of the 2022 IOMS Alasibu NextGen Online Conference. We'd like to thank our moderators and speakers for this session this evening. Do note that all registrants will receive certificates and on-demand video links at a later date. This will be available on demand later on. Our deepest gratitude goes out to Dr. Cecia Gonzalez, who translated this entire session from English to Spanish simultaneously. Our deepest gratitude. And finally, to all over 250 of our live attendees tonight, wherever you are in the world, whatever time it is, thank you for being a part of this. Wherever you are, good morning, good afternoon, and good night, and thank you for attending.